Hi everyone, so as part of the psychology series, it's therapies today. So I'll just go through all the therapies, AO1, AO3 evaluation. So the biological therapy, psychosurgery, AO1. The main components of psychosurgery derive from the medical model of the biological approach. This assumes that psychological disorders have a physiological cause in accordance with the biological assumption of localization of brain function. For example, biological psychologists may attribute a personality disorder to dysfunction of the frontal lobe, where this is seen in the case of Phineas Gage, for instance. Therefore, they may use psychosurgery to treat this condition. Despite this, psychosurgery is a last resort surgical procedure for treating mental disorders by removing or destroying part of the brain to eradicate undesirable behavior. The first component is prefrontal leucotomy, developed by Monitz in 1930. Holes are drilled in each side of the skull. A leucotome is inserted into the brain and its wire loop is rotated to lesion the tissue and sever the nerve fibers. This can be repeated several times. Transorbital lobotomy, developed by Freeman, used an quote-unquote ice pick, which is essentially a special surgical knife, to sever connections between the frontal area of the brain and other areas through the eye socket. This damages frontal areas, which reduces aggressive behaviors. However, the case of Eileen Davey demonstrates the effect of lobotomies. She was irreversibly damaged and she became apathetic or apathetic and had severe incontinence problems, so she couldn't hold back her urine or her bowel movements after a second round of surgery. Stereotactic psychosurgery involves far more precise methods of treating mental disorders. Precise areas of the brain responsible for undesired behaviors are located using MRI scans, meaning that there is no need for large removals of the brain. So every early lobotomies are not used in contemporary societies, only stereotactic psychosurgery. For example, bilateral cingulotomy uses a gamma, so a radiation knife, to surgically interrupt brain circuits to burn brain tissue. For instance, bilateral cingulotomy destroys the structures linking the frontal lobe to deeper structures in the limbic system and induces a positive emotional response. There are also other breakthrough treatments such as precision psychiatry. So this is verified by Riva Posse, Patricio et al., and transcranial magnetic stimulation, which is verified by Carpenter 2012. These I don't think you'll learn in class, but it's just extra things that you can put in, and they'll be useful for your neuroscience debate as well. So, AO3 for psychosurgery. Effectiveness. New breakthroughs in psychology have resulted in non-invasive forms of psychosurgery, such as transcranial magnetic stimulation. This is a non-invasive form of psychosurgery, meaning it is ethically superior to other treatments. With an estimated 1 to 30,000 seizure risk, it additionally puts the patient at an extremely low risk of adverse side effects. So this is effective as it means it can be repeated with little to no side effects. This contrasts early uses of psychosurgery that had a high, so 6% fatality rate, and were largely unpredictable as to the success / side effects of the surgery. So if you looked at the early lobotomies, so the use of the leucotome or the use of the ice pick, you couldn't necessarily reliably predict the outcomes of the surgery. Some people became apathetic, some people were reduced to a vegetative state. Other people, however, reaped the benefits of the surgery. You couldn't necessarily, it was not reliable, however this is reliable. So biological psychologists may suggest that psychosurgery is effective, as it is effective against mental illness when it is stubborn to alternative treatments. For example, 56% of patients of OCD who pursued bilateral cingulotomy reported that it was effective. So this is through Cosgrove and Rauch, 2001. So as to the effectiveness, precision psychology and transcranial magnetic stimulation as non-invasive forms of psychosurgery prove a monumental step in the world of psychosurgery, considering that 50 to 60% of patients unresponsive to alternative treatments experience a clinically positive result. This is verified by Harvard University and the Adam P. Stern. However, like cingulotomy, this means that there is a failure rate of approximately 50 to 40%. This, in the grand scheme of things, is a relatively large population of, that's meant to say people. Realistically, let's say, even if the number of people who were susceptible to seizures, so let's say the number of people in America who had epilepsy was about 3 million people. If 1.5 million to like 1.3 million are still going to suffer from seizures afterwards, that's not a very good proportion. However, the issue remains that 44% of OCD patients would render it ineffective or worse. This is a significant percentage, considering it is estimated that 3 million adults in the US will be diagnosed with OCD in their lifetime. So, let's say all 3 million adults diagnosed with OCD were unresponsive to alternate means of treatment. 44% of them approximately may not reap any benefits, or may come out worse. So that's still a disadvantage as to the effectiveness. So Eileen Davey, with transorbital lobotomies, suffered irreparable brain damage and negative personality changes because of psychosurgery. There was a 6% fatality rate in early lobotomies, which suggests that psychosurgery is not as effective as other therapies, such as drug therapies, considering that side effects are not permanent and are effective in OCD patients. So Sumro 2008. This provides an ethical concern relating to protecting the patient against psychological or physiological harm, as in cases where it is ineffective, it may render the patient in a worse condition. And let's not forget that there is a physical altering of the brain. There is harm being done to the brain. Whether it is a treatment or not, it is still harm to the brain. So Mary Lou Zimmerman demonstrates bilateral cingulotomy not treating OCD, but also causing irreparable brain damage instead. This mirrors the issues with early lobotomy, such as the case of Eileen Davey again, with transorbital lobotomies, where irreparable brain damage and negative personality changes were attained because of psychosurgery. Considering early lobotomies had a 6% fatality rate, this suggests that psychosurgery, so ignore the last bit, so it suggests that psychosurgeries, or early psychosurgeries, did not protect the patients from psychological or physiological harm, and therefore is less ethical than other alternative means of therapies. So the information, the evidence here kind of repeats itself, but that's because, let's say you get a question that's just effectiveness, obviously you won't be speaking about ethics. So if you get a question about ethics, you can still use the same examples. But if you get a question like evaluate psychosurgery or something like that, then you can pick and choose which ones you want. So for effectiveness, you can maybe do like this, the 44% thing and the 6% thing, and then for the ethics, you could do Eileen Davey, because that's more concentrated in terms of psychological and physiological harm. And then you can do precision psychology as another paragraph or something with effectiveness. So, ethical, it is arguably impossible to receive fully informed consent from individuals that receive cingulotomies, as they are often at the extreme spectrum of mental illness, since it is a last resort option. So because in every other case where the mental illness is not as severe, or is, generally speaking, it will probably be responsive to some sort of treatment, whether it's drug therapy or not. Because this is a last resort scenario, the majority of patients that are admitted will be suffering from some kind of extreme mental illness, like stubborn depression, like untreatable depression, schizophrenia, etc. This is an ethical concern, as they may not understand the procedure that they are undergoing. In cases where this procedure results in dangerous adverse side effects, this becomes a contentious issue, because they're causing damage to the brain, and the brain, it will not heal itself. It's permanent damage as well. So let's say if this goes wrong, then there is a patient that has now got to live a life with a permanently damaged brain, and as a result, their quality of life will decrease. However, yeah, cool. So again, precision psychology, transcranial magnetic stimulation, 1 out of 30,000 seizure risk, so it counteracts that point. So when you're evaluating, you always want to say your main point and then offer a little bit of evaluation to your main point afterwards, so you can just kind of include that. So despite the potential harm that may arise after surgery, psychosurgery may be more ethical due to its limited use. Psychosurgery is largely used for disorders that are otherwise untreatable and extreme mental illnesses, not for phobias or disorders such as schizophrenia, which means that the nature of the therapy is designed to minimize potential harm as much as possible. So because it is used as a last resort and because it is not used for the majority of mental illnesses, only those that are stubborn to absolutely every treatment, it means that more likely than not it will work, and where it is used, it's because it is absolutely necessary and it's an absolute necessity to improve the quality of life of the patient. So since 1983 in the UK, informed consent is obligatory for psychosurgery to commence. Moreover, it is not used if a more ethical therapy such as drug therapy, due to its temporary effects, can be used instead. This means that there is an effect in its usage to protect from possible unnecessary harm due to the inevitable risks for negative side effects of psychosurgery. This means that a responsible adult or the patient will be fully informed of the procedure and will give their fully informed consent. So dream analysis, AO1. Psychoanalysis refers to the idea of talking about repressed negative emotions and memories to bring them out of the unconscious, making a client feel better. So this is referred to as catharsis. Dream analysis is used in psychoanalysis. The tripartite model of personalities can be attributed to dream analysis as the id containing our impulsive desires and drives that may be socially unacceptable may take over when we're dreaming because our ego defense mechanisms are low. Our ego defenses are low. This results in us being able to act out our unacceptable desires in an acceptable way. So a lot of people may have overly violent dreams or overly sexual dreams or abhorrent dreams and with the psychodynamic assumption, they attribute this to the tripartite model of personalities. So when you're writing this answer as well for your therapies for the AO1, you always want to link it back to the assumption, link it back to the approach, and the appropriate assumption. So the first component of dream analysis is dreams as wish fulfillment. So Freud believed that all dreams were the unconscious fulfillment of wishes that could not be satisfied in the conscious mind. Dreams protect the sleeper and allow some expression of the buried urges of the sleeper. So this is referred to as wish fulfillment. The second component of dream analysis is the symbolic nature of dreams. Unfulfilled wishes and desires are expressed symbolically to avoid us experiencing stress or anxiety. This refers to the manifest content, what we remember from the dream, and the latent content, the hidden wish, emotion, or desire. For example, dreaming of a boat sailing away may be symbolic of a fear of loneliness. The latent content is turned into manifest content through a process called dream work. Freud believed that this must be contextualized and that sometimes a cigar is just a cigar. So what he's saying that this must be contextualized in the given the context of the client's life. So what Freud is saying is that this must be contextualized in the context of the client's life. And that sometimes, again, a cigar is just a cigar. So that boat could literally just be a boat sailing away. But given the appropriate context, then certain inferences and interpretations can be made by the therapist. So the next component is dream work, where the latent content of a dream is transformed into the manifest content through 4 processes. These include condensation, displacement, symbolism, and secondary elaboration. Condensation refers to the combination of the features of 2 or more people or objects into one image. Secondary elaboration refers to the formation of a logical story, so manifest content, by collecting all images, so condensation and displacement. This further disguises the latent content. The role of the therapist is to reverse the dream work process. The client will talk to the therapist about the manifest content of their dream. The therapist will help guide the client to uncovering the latent content. The therapist will then provide various interpretations based on client feedback and contextual clues. Despite this, it is the client who selects the final interpretation. The therapist will provide various interpretations based on client feedback and contextual cues. Despite this, it is the client who selects the final interpretation considering their circumstances. So, dream analysis AO3 is to effectiveness. So, Hopfield et al. Carried out research into neural networks which were computer simulations aimed to mimic the aim of the action of the brain. They showed that neural networks deal with an overloaded memory by condensing memories. This supports Freud's ideas of condensation, when unacceptable desires are censored and dealt with by combining fragments until they are presented in a new form, the manifest content of a dream by process of secondary elaboration. So, of the effectiveness of dream analysis, AO3, dream analysis has demonstrated to be effective in the treatment of disorders such as depression and anxiety. Matt and Navarro in 1997 reviewed 63 meta-analyses on the effect of psychotherapy and found that 75% of patients undergoing dream analysis showed improvement. I have no idea how to pronounce that, but Schredt et al. In 2000 found in a survey of psychotherapists in private practice that 70% of patients reported benefits from dream analysis. These studies illustrate the benefits of dream analysis as it uncovers the root of disorders. This contrasts with other therapies such as SD and CBT. Obviously though, you can evaluate the 2000 study because it's a private practice. The pilot is likely to be a small pilot study. It's also from the perspective of the psychotherapist, so responses might be biased, might be a bit of social desirability biased, because if they say that patients don't benefit from it, they may be seen in a bad light, so they'll want to be seen in a positive light in the context of society. Also, because it's a private practice, it will be unrepresentative of the general population, because most people to receive private practice are likely to be white, middle class to upper class people. There might be some sort of Asian demographic as well, but of course, for it to be truly representative, it would have to be a range of ethnicities and a much larger sample size. So there will be a decreased amount of external, so population validity in the study, so you could evaluate it by saying that as well. So these studies illustrate the benefits of dream analysis as it uncovers the root of disorders, which contrasts with other therapies such as SD and CBT. So the effectiveness again. So scientific analysis of dream analysis is needed. This is currently lacked. Hobson and Macaulay in 1997 argued that dreams are nothing but commands sent from the brain and are a form of thinking that occurs when we sleep. This questions Freud's suggestion that dreams are an unconscious fulfillment of desires. As dream analysis can't be scientifically validated, it's difficult to support Freud's idea of wish fulfillment without research. Dream analysis cannot be scientifically validated, therefore it is difficult to support Freud's assertion. So it calls into the question of effectiveness, because if our interpretation of what dreams are is incorrect, then how can we treat mental illness using dream analysis? It means that the validity of dream analysis is doubtful, because again, if our interpretation of what dreams are and where they originate is incorrect, then we are not treating the thing that we want to treat. So effectiveness and methodology. So Solms in 2000 used PET scans to highlight the regions of the brain that are active during dreaming. Results showed that irrational parts of the brain are inactive during rapid eye movement, REM sleep, so this is when you're dreaming, whereas brain centers concerning memory and motivation are very active. This suggests that the ego, so the rational and conscious thought, becomes suspended, whilst the id, the self-satisfying, wish-fulfilling, pleasure-driven part of the mind, is not limited in its process. So it means that the pleasure principle is able to be fully enacted whilst you're dreaming. However, you could evaluate it saying that methodological errors include the fact that many sleep experiments involve participants sleeping in a sleep lab whilst wired to various electrodes. Therefore, the ecological validity of experiments can be doubted. This is because dreams in a laboratory are subject to be different to ordinary dreams in a more natural environment. I'm not sure if I elaborate this on the next slide. Yes, cool. So many studies on dreaming are conducted on humans and animals that are deprived of sleep. This causes extreme disruption to biological function, such as secretion of hormones and neurotransmitters. Consequences of sleep deprivation may act as a confounding variable or confounding variables when carrying out research, so results may lack internal validity. Interpreting the manifest content of a dream and revealing its latent content is open to bias/subjective interpretation. Dream analysis relies on the subjective interpretation of the therapist. This will affect the validity of the analysis. Dreams themselves are based on the subjective report of the dreamer. This may not be valid, as the dreamer may feel embarrassed or afraid to report true dreams or be unable to recall dreams accurately, reducing the validity of dream analysis. Dream analysis may innately be methodological fraud. This is because clients may be susceptible to social desirability bias because they may lie about the content of a dream to appear socially acceptable. If Freud's hypothesis is correct, that dreams are our unconscious wish fulfillment, then murderous, violent, or sexually charged dreams may be too embarrassing for a client to tell. As a result, they may lie about the content of the dream. This immediately skews the interpretation of the therapist and may damage the internal validity of dream analysis. This is additionally unproductive, as the client is now receiving treatment for dreams that do not apply to them, as they have not happened. Because there is no way to verify that the client is telling the truth, there is also no guarantee that the therapy is effective. So, ethical issues. Many studies on dreaming are conducted on humans and animals that have been deprived of sleep. So, the short-term and chronic consequences of sleep deprivation may make the research of this therapy very unethical. This suggests that the therapy is inherently flawed, and for it to improve, it must cause harm. So what I'm trying to say here is that for it to be researched, participants need to be harmed via being sleep deprived, which is obviously unethical because there is no protection from physiological or psychological harm. Ethical again. The function of dream analysis, turning manifest content into latent content, may result in a risk of stress, anxiety, or humiliation to participants during dream analysis. Traumatic or embarrassing dreams may result in the participant feeling ashamed or experience negative emotional states such as fear or elicit trauma responses whilst retelling the manifest content of their dreams. The therapist may guide the client towards an interpretation of the dream that is emotionally distressing, as it may uncover past traumatic events. It may also cause false memories, demonstrated by false memory syndrome. The therapist must operate carefully to prevent this from occurring and should interpret dreams given the context of the client's life. So another ethical. There is an additional risk of power imbalance between the client and the therapist. Because the procedures of the therapy are entirely led by the therapist, the client may become dependent on the therapist for progression throughout the therapy. As a result, the therapist needs to carefully manage this to ensure that an over-reliance does not develop. If this was to develop, then the client may not be able to tackle dysfunctional or traumatizing dreams in the future outside of the therapy. Because there is a moderate risk for psychological harm due to anxiety or stress as a result of distressing dreams, it is important that valid, informed consent from the client is attained. It's extremely important, as if the client is not mentally or psychologically prepared to undergo dream analysis, then they may see adverse reactions to the therapy. Because of possible power imbalances, it is important that the client does not feel pressured to continue with the therapy, and that they have the capabilities of withdrawing their consent to participate at any time. So cognitive behavioral therapy, AO1. CBT is based on the cognitive principle that our thoughts influence our behavior. Therefore, mental illnesses such as depression are caused by faulty or maladaptive thoughts and beliefs. The assumption of schemas explains that those with faulty thought patterns have developed negative self-schemas. Beck suggested that depressed people have a negative cognitive triad: unrealistic thoughts about themselves, the world, and the future. This causes cognitive errors, so automatic negative thoughts to surface, such as catastrophizing. So this is the anticipation of extreme outcomes. So let's say that you are extremely depressed, or you have clinical depression and you suffer from catastrophization, then if you're about to take a test, then you may automatically convince yourself that you're going to fail. This is obviously disadvantageous as you're experiencing stress. If your partner goes out for the night, you may convince yourself that they are going to run into trouble, or they might get attacked or something like that. So it's the anticipation of extreme outcomes that are unfounded. So the first component of CBT is a dysfunctional thought diary. A client is asked to keep a record of events leading to any unpleasant emotional experience. A client writes their automatic negative thoughts associated with these events and rates how much they believe in them from 1 to 100. Then they must write a rational response to the automatic negative thought and rate their belief in this rational response from 1 to 100. The next component of CBT is cognitive restructuring by challenging dysfunctional thoughts. Once the client has revealed more about their thought patterns, they work together with the therapist to identify and change negative thinking patterns. They are tasked with challenging their dysfunctional thoughts by asking, what is the evidence of X? What is the worst that could happen if X were true? The next component of CBT is pleasant activity scheduling. This refers to a client being asked to plan a pleasant activity for each day over a week. This could be a break of routine or a sense of achievement. This will help the client to change their behavior, as it will detract them from negative thinking patterns. They will keep a record of the activity and their emotional state during. The client, if it does not go as planned, is encouraged to consider why that might be and what might be done to change it. This empowers them over their negative thinking patterns. So despite this, evidence suggests that CBT is highly effective in treating depression and anxiety related problems. Cahill et al. In 2003 found that at the end of a therapy of 12 to 20 sessions, 71% of patients who had completed their therapy experienced significant reduction in their symptoms. However, 13% of patients who did not complete therapy showed improvement. This demonstrates that full completion of the therapy is crucial to reaping the rewards, which outside of NHS treatment may be behind a paywall. Also, according to the study, this means that there was not a significant reduction of symptoms in 29% of patients. So this could range from adverse symptom responses, so negative symptoms being exacerbated, or it could be moderate improvement, or it could be very minor improvement. So if you have paid money yet you don't reap the benefits, then it calls into question the effectiveness of the therapy as well. 29%, nearly 30% is a large value. So, effectiveness and ethics of cognitive behavioral therapy. This is unethical, as it means that there is a cost to having a better quality of life. However, this also suggests that even without completion, there is still a margin of effectiveness of the therapy, but it means that 87% of other participants possibly spent money and time for no improvement or a worsening of condition. If we're using the 13% statistic, obviously 87%. So So Koikin and Civikas in 2009 found that 15% of the effectiveness in CBT may be due to the competence of the therapist, suggesting that it is very much dependent on their control. This is a disadvantage of both CBT's effectiveness and ethics, as it demonstrates that the effectiveness of CBT is dependent on the professional. This means that the quality of therapy will differ depending on the therapist, such as the institution where it is being received from, meaning that therapy is not standardized. Moreover, standardization, a lack of standardization, is an effectiveness issue slash methodological issue. Moreover, this is also an ethical concern, as people may face psychological harm if the treatment is ineffective, as the nature of the therapy may predispose them to psychological harm anyway. So, effectiveness of cognitive behavioral therapy. CBT has been shown to be most effective in combination with other therapies, such as drug therapy in the treatment of schizophrenia. Despite this, CBT has been seen to be just as effective as some antidepressant drugs when treating 108 patients with severe depression over a 10-week period. This is conducted by Jarrett et al. No difference in CBT was found when compared to a different antidepressant drug in a sample of 107 participants over a 10-week period. So Holland et al. Suggesting that it may not be superior to antidepressants, and those with extreme depression caused by purely neurological factors should not undergo CBT. However, it could be argued that having a non-drug related therapy that reaps the same benefits as drug therapy is an advantage for the effectiveness of the therapy, as it means that the client will not have to suffer the same side effects that they would ordinarily have via drug therapy. So, effectiveness again of CBT. Another disadvantage for the effectiveness of CBT is that because blame is placed on the client, it may be incompatible with the treatment of extreme personality disorders such as BPD, psychopathy, or psychotic disorders such as schizophrenia. This means that not everybody is able to receive CBT, which is a disadvantage to its effectiveness. This may suggest that it is more suitable for some people compared to others. So Simmons et al. Suggested that CBT appears less useful in those who have high levels of irrational beliefs, resistant to change, and those whose stress reflects realistic stress in their life that cannot be resolved by CBT. So let's say if you have a soldier that consistently goes to war, CBT may not be effective because the stress is relative to their lifestyle. So ethical issues. Client blame may result in them encountering psychological distress as they are told and they learn that their entire thought process is flawed. This may additionally lead them to encounter self-esteem issues because of this. Acknowledging and changing this may be distressing enough, which may prove incompatible with clients with extreme psychotic personality disorders such as BPD or psychopathy. So ethical again, some may suggest that CBT is not effective as it may give the client a false perception of reality. The quote-unquote sadder but wiser effect suggests that depressed individuals are wiser since they are more accurate at predicting outcomes. Non-depressed people are argued to live life through a quote-unquote rose-tinted glasses, and non-depressed people are argued to live life through quote-unquote rose-tinted glasses and have false expectations that leave them disappointed. CBT may do more harm than good, destroying a depressed person's ability to correctly predict outcomes of situations. This can be explained as a psychologically damaged individual may lose the ability to hope or dream of future aspirations, over applying the methods of CBT to predict a realistic scenario of success for every event in their life, which may limit them. So there may be other factors that lead to their prediction. And if they believe that their prediction is the most accurate prediction, then they may limit themselves. So for example, somebody that hopes to be a doctor most likely will become a doctor with hard work. That's not necessarily out of the realms of the unordinary. Obviously, with aspirations such as making the NBA or the NFL or the Premier League, there's a lot more intricate factors such as luck or connections or talent, which is arguably not a real concept, but that may come into play. But somebody with depression may doubt themselves ever becoming a doctor based on factors outside of their predictions, because their predictions are also based on their schemas and what they've experienced before in their life. That's the only way they can make predictions. So if that is inherently flawed, then they may believe that their realistic chance of success, or a realistic scenario of success, is actually something that would limit their progress. So positive assumption therapy, mindfulness, AO1. Mindfulness refers to the concept of noticing what we don't usually notice, the aim of which is to allow people to be in control of their mind by paying attention to their present thoughts and emotions. This can be applied to the assumption of acknowledgement of free will. It involves the individual becoming consciously aware of their present thoughts and feelings through attention and self-regulation. Therefore, the therapy aims to enhance a person's characteristics through acceptance-based methods which develop the individual's core virtues such as gratitude, flexibility, and optimism. The first component is gaining control of thoughts, training ourselves to focus on our present thoughts and feelings. Too much focus on the past can create thoughts of regret or guilt. However, too much focus on the future may create unnecessary thoughts of worry and anxiety. The next component is meditation and mindful breathing. Formal training in meditation is the most effective way of developing mindfulness skills, as it removes the individuals from their daily interactions with life, so it allows them to focus with less distractions. Meditation is also learned through guided instructions and practice. This may also help with managing negative intrusive thoughts by reducing impulsive action to their negative thoughts. The next component is informal practice of mindfulness. This is the opposite of multitasking and is making a conscious decision to focus on a single task, paying attention to your surroundings. This can be something as simple as considering the taste of your food that you're eating. Methods include basic mindfulness of keeping intricate attentiveness to bodily sensation or sensory information. This can reduce feelings of depression and anxiety and improve sleep and concentration. A type of mindfulness course is mindfulness-based stress reduction, which aims to address prolonged periods of stress. This incorporates techniques such as meditation, gentle yoga, and mind-body exercises to help people learn how to cope with stress. MBSR makes the experience a challenge rather than a chore. It places importance on individual effort and motivation rather than what somebody feels like practicing on a particular day or not. So, the effectiveness of mindfulness. The effectiveness of mindfulness is also boasted due to its accessible nature in children and applicability to school/nursery curriculums. For instance, Kuken et al. 2013 compared children in secondary schools who took part in mindfulness school programs to those who took part in normal school curriculums. Children involved with mindfulness had less stress, greater well-being, and fewer depressive symptoms compared to the control group. This demonstrates the importance of the implementation of mindfulness for the upkeep of a child's well-being, especially inspired by the mental health crisis amongst young people. Plus, you could also factor in the fact that because they're a vulnerable group, it's even more vital that mindfulness is implemented into school curriculums. Also, the fact that children do not necessarily have the autonomy to monitor their mental health yet because they're not psychologically developed enough. The Mindfulness Used in Schools project for 2007 taught mindfulness in 12 different countries and was a 9-week course involving a curriculum designed to help concentration of learners dealing with bullying, exam anxiety, and general study skills. This was shown to be effective in improving student well-being. This also demonstrates that mindfulness is suitable for all age groups as it is applicable to different scenarios, increasing external population validity and the generalizability of the study to varying demographics. However, research has shown that mindfulness is effective due to its comparison with other treatments. Williams et al. Compared mindfulness-based cognitive behavioral therapy with other treatments in people who had previously suffered from depression. That's meant to say MBCT, not MBCBT. They were randomly allocated to each condition and followed up a year later. MBCT provided protection against people with a history of childhood trauma. However, they did not show significant change in other participants. This may be explained by several factors, however. The medical model may mainly explain this. If the participants had brain dysfunction that resulted in their depression, no amount of mindfulness would be as effective as other forms of treatment such as drug therapy or psychosurgery, as it is a physiological issue. However, the effectiveness of mindfulness is doubted due to the study's methodological shortcomings. Professor Patricia Casey argues that research supporting mindfulness are small pilot studies. A small sample results in inflated and therefore unreliable findings and conclusions. Moreover, she argues that participants are at the mild end of the mental health spectrum, suggesting that there may be deficits in the effectiveness of mindfulness when it is applied to those suffering from extreme mental illnesses, such as crippling depression, phobias, or developmental disorders such as autism and Tourette's. This may suggest that more established and reliable therapies, such as CBT and pharmaceutical interventions, such as SSRIs for depression, are more effective. Therefore, the validity of mindfulness is limited. An ethical disadvantage is that mindfulness does not address the root cause of psychological disorders, making it immediately incompatible with extreme disorders such as schizophrenia. Trauma-based illnesses such as PTSD, post-traumatic stress disorder, may be even more so incompatible, as mindfulness may in fact trigger PTSD attacks. This is because the root cause of the illness is not a dysfunctional thought process or a lack of subjective well-being, but trauma. This needs to be addressed through therapy with a professional at the pace of the client and the therapist, rather than through mindfulness. Besides that, undergoing mindfulness training whilst suffering from the disorder may elicit symptoms and adverse reactions instantaneously, as these thoughts will be present. An ethical advantage, however, of mindfulness is that it is largely very ethical, considering there is a lack of psychological harm that may come to the client compared to other therapies. For example, drug therapies or psychosurgery may cause irreversible side effects to the client. Drug therapies for depression often have adverse side effects, zombie-like emotional states for people. However, mindfulness obviously does not. Moreover, drug therapies and psychosurgery cannot be used on children. However, mindfulness has universal applicability and no chronic or overly damaging side effects. It can also help to empower the client, to encourage them to take control of their own dysfunctional thoughts by forming a positive approach towards well-being. The universal application of mindfulness to all groups also adds to its status as being ethical. If mindfulness was only accessible to a select group, then the predominant usage of it as a therapy would be unethical, as it is predisposing a disproportionately large percentage of society to psychological harm. This is because they would not be able to access the treatment, leading to net psychological harm. This is apparent in most other therapies, which the range of effectiveness changes depending on cost and origin, so location of the treatment. So this is most seen in free versus private healthcare. However, mindfulness can be performed by everybody, anywhere. Despite this, there is a minor paywall, as for mindfulness to be fully effective, it must be professionally taught prior. However, it is still largely available to the average layperson. It gives all people, regardless of their circumstance, the ability to increase their subjective well-being by giving them the motivation to manage their thoughts and improve their lives. Furthermore, through the advent of the internet and other media forms, you can likely vicariously receive mindfulness training through YouTube or something like that, but you can't necessarily do the same through CBT. So AO1 for systematic desensitization. A phobia is an irrational fear of an object or situation which, according to the behaviorist approach, is a learned response to a stimulus or stimuli. The behaviorist approach assumes that all behaviors are learned, therefore phobias are also learned. As a result, systematic desensitization uses the principle of reciprocated inhibition to counter-condition the individual to no longer fear that phobia. This was developed by Warp in 1958 after Masserman's study that conditioned cats to be scared of a box via electric shocks. Warp conducted studies to reverse this conditioning by feeding them in the box. He assumed that a similar process could be applied to a phobic behavior or phobic disorders. The first component of systematic desensitization is the learning of relaxation techniques. Deep muscle relaxation techniques such as meditation and controlled breathing are taught by the therapist. This uses the theory of reciprocal inhibition to inhibit anxiety and induce relaxation. This states that you cannot feel two opposing emotions at once, such as anxiety and fear. Learning relaxation techniques allows for a better chance at counter-conditioning the client to associate the previously fear-inducing situation or object with feelings of relaxation. So this is reinforced by Masserman and Wolpe. The second component of SD is the creation of a hierarchy of fear. This involves the client working with the therapist to place the least to most fear-inducing scenarios in relation to the specified object or situation in order. For instance, if a client is scared of spiders, they may place imagining the spider on lower on the list than an image or a physical interaction with the spider. The next component of SD revolves around the client progressing up the hierarchy until they complete it and no longer suffer from the specific phobia. This is client-led and involves two types of graduated exposure: in vivo or in vitro desensitization. In vivo refers to being within the presence of objects or images that would usually induce fear. However, in vitro refers to learning to relax whilst imagining the presence of a feared object. Behaviorists believe that all behavior is learned. Therefore, they believe that using graduated exposure techniques with their phobia and working up the hierarchy of fear in conjunction with the relaxation techniques will induce reciprocated inhibition, and therefore they will learn to be relaxed in the presence of stimuli that previously would invoke a phobic reaction. An individual can learn that their feared stimulus is not fearful at all if they could re-experience it. However, the feeling of anxiety often presents this. Therefore, reciprocated inhibition is used by subjecting the client to deep muscle relaxation techniques, as it is impossible to feel relaxation and fear simultaneously. The client creates a hierarchy of fear and is made to relax at each stage of their hierarchy and progressively gets to more fearful situations. This is client-led graduated exposure. So, within two forms again. So for somebody with aerophobia, they may imagine a scenario and then flying on a plane is higher up on the hierarchy. So, AO3. Effectiveness. SD proves to be effective in the treatment of phobias, shown by research conducted by Rothbaum et al. He conducted research where people with aerophobia received SD and compared results against a control group who did not receive treatment. He found that 93% agreed to take a trial flight and had much lower levels of anxiety than the control group. These effects were shown to persist 6 months after treatment. Both the initial and follow-up observations demonstrate the short-term and long-term benefits of systematic desensitization. Therefore, systematic desensitization is effective. 7% did not find this effective. If expanded to the size of the population of the UK, considering roughly 168 to 336,000 people suffer from aerophobia, at least 11,700 people would still feel so fearful of flights after treatment that they would refuse to participate in a trial flight. This is a disadvantage because it means that in cases where they have spent money to receive that treatment, they have spent money and time and likely maybe taken time off work or sacrificed other means in their life to pursue treatment to not reap results whatsoever. So, systematic desensitization can be ineffective for some phobias. This is because it does not universally counter-condition all phobias, especially those that have not evolved from personal experience via classical conditioning. For example, a fear of heights that does not result from personal injury or a traumatic event may be untreatable with systematic desensitization. This is because some fears are argued to have been developed evolutionarily, according to evolutionary psychologists, suggesting that these ancient fears, quote-unquote, do not have an environmentally determined cause, but are rather hardwired into the behaviors of humans as a species. A fear of the dark or the theorized uncanny valley or a fear of snakes may be examples of this. The effectiveness of SD may be also doubted in case of symptom substitution. This is because it focuses on removing the symptoms and not the cause. Therefore, the symptoms may resurface and displace, manifesting in another form. For example, the case of Little Hans demonstrates this, as fear of his father transferred to horses upon receiving SD. SD may not be effective in those with neurodevelopmental disorders such as autism or hypersensitivity, and only effective in those who are neurotypical. For instance, neurodivergent individuals may have a sound phobia because of the discomfort experienced due to their hypersensitivity. However, this is not something that can be treated with exposure therapies, as it is due to their neurological composition rather than a learned behavior. The cause of the discomfort is not a learned behavior again. Also, people with autism may have difficulty generalizing techniques and learning from one context to another, and understanding abstract concepts such as relaxation techniques may be difficult. This may inhibit their ability to apply such techniques to real-world scenarios. However, they may excel at this in therapy. Cognitive behavioral therapy or social skills training may be more effective for those with neurodevelopmental disorders. So, ethical implications. Some may suggest that systematic desensitization is unethical as it exposes the client to possible psychological distress via stress or fear. However, there are two components to the therapy that counteract this. The creation of the anxiety hierarchy for the patient allows for the client to establish a rate of progression that they are comfortable with progressing through. Moreover, the client-led nature of the therapy, that's meant to say therapy, do not say experiment. The client-led nature of the therapy means that the client only goes up the ladder if they feel comfortable to. They're also able to go back down the ladder if the next stage is too daunting for them. Furthermore, the client or clients are taught relaxation techniques before they are exposed to any stress. This means that the nature of the therapy inherently aims to minimize the amount of psychological distress that the client feels, unlike flooding, which may cause maximal psychological harm or distress as they are made to face the highest level of anxiety relative to their phobia. Lastly, while there is a chance that the client experiences a degree of psychological harm, the therapy could be argued to protect the client from future psychological harm, so it cancels out. If the client becomes counter-conditioned at the end of the therapy, then they'll be equipped with the necessary thought processes to tackle and overcome situations that previously would have caused them harm. This may lead to an improved quality of life, which is an ethical advantage. Even though anxiety is felt during therapy, it is no more anxiety than they would experience in a normal circumstance when faced with their phobia. Any anxiety felt is replaced with relaxation. A lack of informed, valid consent is rarely an issue with systematic desensitization. This is because a phobia is far less likely to impair an individual's ability to consent, unlike extreme psychological disorders such as schizophrenia. This means that clients consenting to participate in systematic desensitization are fully aware of the procedures. This also means that if they suffer from psychological distress, they'll be fully aware of the occurrence of it, which may dampen the effects of such as they will not be mentally prepared. Furthermore, the client-led nature of SD also means that there is a decreased chance of the client becoming dependent on the therapist, which contrasts dream analysis. This is because SD increases the individual's feelings of control, considering the role of the therapist is more akin to a guide rather than centrally involving themselves in the client's development, beyond the teaching of relaxation techniques and the establishing of a hierarchy of fear. But even that, the therapist isn't necessarily that involved. This contrasts other therapies such as dream analysis that may develop a more lopsided client-therapist relationship. Therefore, the argument could be made that SD is more ethical than other therapies because of this.